Okay, we're going to talk about nutrition, fluids, and electrolytes as part of this lab. So let's move forward here if I can get it to. So our very first thing that I want you to think about is how you as a nurse are going to promote health and nutrition for your patient. There's a lot of things that we do, but when you think about it, it's truly helping our patients get better, heal, all of these wonderful things. So here on my next slide, if I can get it there. Next, as nurses, we encourage dietary compliance, right? We help to encourage our patients to stay on the diet or meal plan that has been prescribed to them by their provider, okay? We help to serve meal trays. In many facilities, that's primarily up to the nurse's aide or the certified nurse's aide, but we as nurses, we can pitch in whenever there's a need. We can also help to pitch in to help feed patients. It is probably one of the most boring jobs ever to feed a patient, but it's probably one of the most rewarding and probably one of the most important things that we do, because if your patients can't eat, then they can't get better, right? We help to make sure that patient weights are recorded appropriately, that their intake and output is put into the computer system or into the charting. We also observe our patients for signs of poor nutrition. Now think about that. What would be some signs of poor nutrition? Dry mucous membranes would be the first one on my list. Constipation could be another one. A patient that has dry, cracked skin, that could also be another thing that would be a sign of poor nutrition. Another thing that we do as nurses is we communicate with other members of the healthcare team. We're just one person, and we really truly have the closest eyeballs on the patient. And if your patient's not eating, if your patient hates what they eat, let dietary know. I mean, they're going to continue to serve the same things if the patient doesn't let us know any different, right? So we can help to communicate with the team. We can also communicate with the provider and say, hey, you've got this patient on a low carb diet, and that's fine, but they don't eat any of their carbs anyways, whatever. We want to communicate what the patient's really doing, right? The provider writes an order and doesn't stick around for dinner. The provider, we're the ones that are there for dinner, right? We're the ones that know what's really happening with our patients, okay? So next, this basic nutrition. We used to have the food guide pyramid, and now we have this choosemyplate.gov. And if you Google that, it'll take you to something close to this. It's probably been a little bit updated, but truly it's to plan and balance what we eat, right? So the first thing up on our list here is it balances the calories, right? It helps us to enjoy our food, but eat less of the things that we probably shouldn't be eating. It helps us to avoid oversized portions. There's bigger spots, like the vegetables and the fruit are bigger, right, than the dairy, right? To make half our plate fruits and vegetables and the other half grains, whole grains, right, and proteins, okay? It talks about foods that we should eat less often, and it also, helps us to recognize that foods that have high sodium, or recognize what foods, right, have higher amounts of sodium. And drink water instead of sugary drinks, okay? And so here's a little website to choose my plate, if that's something you'd like to look at. So the essential nutrients. Essential nutrients are nutrients that our body doesn't naturally make that we have to eat to get into our bodies, okay? Essential nutrients help to provide energy. They build and repair tissue. We have to make sure that we give proteins and carbohydrates and fats so that we can heal wounds, right? These are all things that are mandatory. Um, they help to regulate the processes of the body. I mean, even just to sleep, we need energy to sleep, right? We need energy to do nothing, right? We need energy. So carbohydrates give us energy. Fats help to give us satiety or help us to feel full, right? And then proteins help our fluid balance. We'll talk a little bit about that in a few minutes. And then proteins help to build and repair tissue, right? And that's where that wound care comes in. Now, you see this 4 kilocalories and 9 and the 4. You do not need to memorize that. But just know that you're going to get more bang for your buck with a carb and a protein than with fat. Okay. Did I go too far? I did. Like, wait. Whoa, 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 whoa. It's running away from me. You're getting a whole preview. Okay, vitamins. Many of you know this. Many of you have taken dietary classes, but this is a nice kind of little overview of vitamins and the essential nutrients and those kinds of things. So we start with water soluble vitamins. Water soluble vitamins are not stored in the body. We need them every day, and they're excreted in the urine if you take too many. Like when I was in college, I used to think that, oh, if I took a lot of vitamin C, it'll keep me from getting sick. Well, it kind of did, okay. But I had to take vitamin C every day. I couldn't just take a ton of vitamin C and it would stick with me through the entire semester. Fat soluble, now that's stored in the body, okay, and it's carried in fats of foods, okay, and these fat soluble vitamins are A, D, E, and K. You don't have to have that memorized, but it's kind of nice to know which vitamins you need every day and which vitamins can be stored in the body. And then we have antioxidant vitamins, and these help to keep us from having cells prematurely die, right? They help us with anti-aging and they help us with anti-tumor. Now, tumors come from when healthy cells start to replicate not differently from its original. Okay, and so antioxidant vitamins help the cells replicate exactly the same, so they don't turn into cancer or tumors. So vitamin C or ascorbic acid, that helps with to support our immune system. It helps with wound healing. It also helps us to absorb iron. We'll talk more about iron deficiency anemia later in the semester, and you'll see that we need vitamin C with that iron so the iron is absorbed appropriately in the body. Many people think that vitamin C help us to stay away from the common cold. Vitamin C is found in citrus fruits, and one very common disease that was kind of the pirate's disease was scurvy, because pirates are on a ship for long periods of time, and they don't have access to fresh fruits and vegetables where vitamin C is found. People still can get scurvy today, but it happens not quite as often because we have such a fresh supply of fruits and vegetables around us. Vitamin D, when I think of vitamin D, I think of milk, okay? And milk being fortified with vitamin D, and here's kind of a picture of some of the things that vitamin D is found in. Vitamin D and phosphorus kind of work together. Vitamin D helps with that phosphorus balance. So we'll find vitamin D in milk, but we also get vitamin D from the sun, and it can be absorbed through the skin. Many of you know this. Living in Arizona, you'd think that everybody would be well up on their vitamin D, but I'll tell you, when it's summer, I hibernate. I'm wearing a sweatshirt. It's actually a sweatshirt dress. It's my favorite thing. and I love it in these times of teaching from home. It like my husband likes the air conditioning up. You don't care, but I care. My husband turns the air conditioning down, and I freeze in my little office back here, so I wear a t-shirt dress. It's the best. Anyways, when we don't have enough vitamin D, bones can become soft. Okay, here's that calcium. It helps with calcium. And so rickets is where the bones would bend, okay? And then this is a disorder where our bones aren't very strong either, okay? I can't pronounce it. All right. Vitamin K, vitamin K. When I think of vitamin K, I think of clotting, okay? It helps us to clot, okay? Now, if you've got a person that has a clotting disorder, vitamin K is going to be wonderful for them to take long term, right? If you've got a person who's bleeding out, vitamin K is not going to work, okay? But if you've got someone that's got a clotting factor disorder, we would want them to increase their consumption of these following things. I'll tell you, liver is on almost every page. Any of you out there who eat a lot of liver are up on all of your vitamins and minerals. There's everything in liver. Iron. Here we go. Iron. Iron is essential for our red blood cells. Okay, it helps us with hemoglobin, it helps us to bind oxygen to these little red blood cells. Okay, so it helps with oxygen transport. Iron's in a lot of different proteins and fortified grains and soy. Okay, if we don't consume enough iron, then we can develop iron deficiency anemia, which is never good because then you feel really weak and you just don't have a lot of energy and your O2 can be low. So B complex vitamins, okay? So vitamin B12, niacin, and folate are all B vitamins, okay? The first one that we're going to talk about is vitamin B12. Vitamin B12 is found in a whole lot of different foods, mostly found in proteins, okay? They help to give us energy, and and vitamin B12 helps to actually make our red blood cells round and juicy. I know that sounds weird, but it does. It plumps up the red blood cells. Vitamin B12 also helps in like new cell creation. It helps us in our nerve cells. Our nerve cells are like gold, right? So we want vitamin B12 to help nourish the nerves, right? If we don't have enough vitamin B12, we can develop an anemia called pernicious anemia. And we'll talk a little bit more about pernicious anemia when we do GI, but just think, if we don't have enough vitamin B12, our red blood cells are going to get smaller and not be as buoyant, and we're going to have less energy, okay? Niacin helps with, there's some, wives' tale that niacin can help lower cholesterol. That's one of the B vitamins. And then folate, we think of pregnancy and making a baby, not making a baby, but, the baby growing inside, okay? And we need a lot of folate to make that baby come out looking like the cutest baby ever. So some special considerations, just to make sure that I'm not missing anything. I feel like I'm flipping through these pretty quickly. Special considerations, we're going to talk about some of these things: pregnancy, infancy, childhood, adolescence, and being an elderly patient. So pregnancy and lactation, nutrient needs increase. Now, why do I need to know this as a nurse? Well, as a nurse, you're going to help a person who is pregnant and help them along their journey. You may work in the clinic, you may work on the floor, you may work in all sorts of, you may be a great neighbor, right? You just need to know these things. Now, truly, there's some there's an old adage that if you eat for two, you'll look like you're eating for two, right? We just want to increase in these nutrients, okay? Calcium, folic acid, protein. It all winds up to be about 300 to 500 calories in increase a day, which isn't a ton, okay? The appropriate weight gain, they say, is about 25 to 35 pounds, depending on how much the woman weighs before she gets pregnant. If she's underweight, she may need to gain more than 35 pounds. If she's average weight, then it may be just closer to 25. Okay. There's lots of nutritional discomforts and a lot of nutritional complications, right? Nutritional discomforts would be nausea, morning sickness, right? Constipation, right? Um, your book talks about some of these things. Some of the complications of being pregnant is high blood pressure, um, low blood sugar or high blood sugar, right? So we watch and we monitor these things very closely. Some practices to avoid, there's some fishes that they don't want you to eat, feta cheese, getting in hot tubs. There's a few things that are really not great for the baby's growth inside. So infancy is defined birth to 1 year is an infant, okay? During this year, the baby is going to double in their weight by 6 months. That's a lot of growth from teeny tiny to now you're double, right? Most families decide, and moms and families decide that breast milk is where they want to be. Some breast milk is where they want to be, but that just ain't happening because life is not allowing that to happen. Okay, and so whether it's breast milk or whether it's iron fortified formula, that's up to mom and the family. Okay. Usually about 4 to 6 months, solid foods will start to be introduced. Okay, that doesn't mean that the milk piece goes away. It just means we add extra foods in addition to that. Usually we want to add one food at a time, 1 week apart, so that we can be monitoring that baby closely if they have any allergies. If we give the baby too many new foods and they develop an allergy, we don't know what food that is. Childhood. Childhood is a great time for parents to help teach their children good dietary habits. It's a great way for parents to offer a variety of foods. It's very hard. Some kids are very, very picky, and some parents get very frustrated around dinner time when foods are not eaten like they think they should be eating. Okay, but truly, the professionals, the research has shown that if you don't force kids to eat, they will eat when they're hungry. They're not going to starve themselves. They will eat when they're hungry, and if they're easily distracted, that's okay. They will come back and they will eat. Just make nutritional snacks and nutritional foods available and to limit sweets. So, adolescence. Adolescence is a gigantic time of growth, physical and emotionally. They're growing, they're figuring out who they are, and their bodies are changing, and things are happening, and they're starting to feel things, and they're going to fall in love, and they're going to have all these things are going to happen that they need good nutrition. They're going to have a lot of peer pressure. They're going to want to eat things that their friends are eating, and sometimes they don't want to eat more than what their friends are eating or eat too much less than what their friends are eating. It's a mind, it's just their mind is being blown by all these things. Poor kids. And really, truly, kids should have an increase in vitamins C and A, iron, folic acid, calcium, a lot of protein. I don't have that here, but they really need extra protein, especially for their hormones. I think that, yeah, I've had many, I don't have any children, but I have many nieces and nephews. I have like 25, 26 nieces and nephews and counting. And my nieces and nephews who don't eat protein are like emotional roller coasters. So that's just a word for the wise. I don't know if anybody cares. But as as nurses, we want to help to instill as good of eating habits as we can, knowing all of these things are happening around them emotionally and physically. We want to help support them in their growth. Now, as we get older, I talked a little bit about this on the head to toe data collection lecture, that everything starts to slow down, right? Their energy needs decrease with age. There's changes in the eating process, right? They don't have their own teeth. They take medications, so everything starts to taste different. Like there's some medications that make patients feel like they've got metal in their mouth, and that's not very great. Um, so aroma and taste change, just not just the sensory piece of it, because their sense, like their smells changes and their taste changes, but the meds make things change. So we need to help increase your patient's eating of nutrient-rich foods. Now, what would that be, Suze? What would be a nutrient-rich food? Well, like Boost or Ensure, right? The shakes that have all the protein, those are all the rage, right? The premier protein drinks, those would be awesome. They taste good and they pack a power punch, right? As we get older, that food interactions with the medications, we'll talk more about MAOIs next week when we do psych, but MAOIs are a very potent psychotropic med that has many food interactions. Um, as we get older, we become depressed. We don't want to eat, right? My dad's, well, they're just right around 80. My dad's 81, my mom's 79, and truly all their friends are starting to die. And it's the most depressing thing for them. And I can't help them. I wish I could, and they don't want to eat very much, and they're losing a little bit of weight. So it just, getting older is just the pits. And so as nurses, we need to help them as best as we can and be understanding with that change, right? And we want to not only assist them, but encourage them to eat, right? When we go into our patients' rooms and we see that Ensure or the Boost or whatever it is they're eating, and be like, oh, that muffin looks really good. Do you want me to cut it up for you? Do you want me to help you eat that? Encourage them to get those nutrients. As we age, our bodies are aging, and we're going to be on a restricted diet, like low sodium and low fat and low fun and nothing good, right? But try to be positive with them. As we get older, you'll find your patients are very cautious about how much fluid they take in, because it's harder for them to get to the restroom and they don't want to drink a lot. But when they don't drink a lot, they become dehydrated, and then they can get confused and become like all sorts of not good things, right? So being as positive as you can and helpful will help those who are getting a little bit older. We're going to talk about water. Water, the life force. Doesn't that just make you want to drink water? Kind of makes me want some water too. So water is essential to life. We need 2 to 3 liters a day, and living in Arizona, we probably need more. But c'est la vie. It is what it is. Okay? So water is the route, right? Water, our cells are like a boat in a river of water. And if we don't have enough river of water, the cells can't do what they need to do, and nutrients can't find its way from one cell to another. So we need water in our bodies to help transport nutrients around. Water is also the medium where chemical reactions take place. And water helps to lubricate our food. It helps with digestion. It helps move stool through the system. Water helps us to maintain our acid-base balance. And heat helps us to regulate, or water helps us to regulate the heat and the cold in our body. And it keeps us from overheating, which is important when you live in Arizona. It's hot here. So, some key water facts. Most of our body weight is water. Okay, and the older that we get, it's going to change how much water we really need. Okay, so a normal healthy adult, their percent of their body is about 60% is water. Infant is 80%, so they are way more water than you would even think. As we get older, that percent of water goes down, which also puts them at risk. Okay, and then someone who's overweight, they have even less water, probably because they don't drink enough water, right? So our percent fat also affects our water amount. So the more overweight we are, the less water we have, which is dangerous too. Okay, that's why most weight loss journeys start with drinking water, because it helps to get things, right in their body. So some other adult considerations, okay? As we get older, fat replaces lean muscle, okay? And that also contributes to the decrease in water percent of the body. The older kidney is unable to concentrate urine. They stop drinking fluid because of that, incontinence issue and getting to the bathroom. They want to increase salt in their diet because that makes things taste better. Okay. That dehydration is masked with confusion, and that's a problem. And then when we don't drink enough, we get constipated. We can get constipated. So we're going to talk a little bit about different types of diets. Okay. Liquid diet, soft and low residue diets, high fiber, high calorie, high protein, and then controlled calorie diets. So, liquid diets, okay? Usually, your patient, we want to put patients on a diet that they can tolerate. And I know that may sound confusing, but we don't want to make people sicker with what they eat, especially in facilities. So if you've got a patient who just had surgery and they come out of surgery, the first thing that we let them do is we give them sips and chips, which is ice chips and water. Okay, just little sips to keep their mouth dry. Ice chips help to keep, a patient feeling like they're not like a cotton mouth, right? But we don't want to give them too much because their GI system can't tolerate too much just yet. Okay. Then we advance them up to a clear liquid diet. Now, clear liquids are anything that we can see through. Okay, popsicles are great on a clear liquid diet. Apple juice, most juices are clear liquid. Water, of course, is clear liquid. Coffee with no dairy, right? Coffee with no creamer. That would also be a clear liquid diet. Now, the next step up would be a full liquid diet. And full liquid means we can add dairy. So your patient can have now their coffee with their creamer. They can have yogurt even. They can have soups that have like a cream-based soup. Okay. Usually when your patient goes from a clear liquid diet to a full liquid diet, this is where they might feel a little nauseated. Usually going from sips and chips to a clear liquid diet, everything's okay, right? But that addition of dairy is kind of like the game changer, okay? So if you're in a facility where your patient starts to feel nauseous out of nowhere, maybe they made that step to that dairy, and that's okay. We can always go back to the clear liquid or lay off of the dairy a little bit. So a soft or a low residue diet, as you can see on this plate, soft or low residue diet is kind of boring, okay? But it's soft, okay? And there's a couple different reasons why we use a soft or a low residue diet. Number one, it's a transition diet. Okay, so you've got a patient that's a full liquid, and now we're easing them into a regular diet, right? This is very easily digested. There's no seeds, a low fiber, right? So you've got a patient that is on a soft diet. Usually we're transitioning them to a regular diet. Sometimes this is all they can handle. Sometimes they're, because of different disease processes that are happening, okay, acute diverticulitis, they've got an inflammation in their large intestine, or they have irritable bowel. Gastritis and upset stomach are a lot the same, right? Some of you have heard of the brat diet, bananas, apples, toast, and I don't know what the R is, rice, B-R-A-T. It's just very easy to digest, and it's good after you've been sick to your stomach, okay? So this is what that kind of a diet, okay? Some people are on a very soft diet because they don't have real good teeth. This is all they can really eat, okay? This, I'm afraid, this green thing, I'm afraid is broccoli. Who wants to eat broccoli like that? I would not. But anyways, that's a soft diet. So high fiber. So now we have a regular diet, but now we're upping the amount of fiber, okay? So we're upping the amount of fresh fruits and fresh vegetables. High fiber is a little bit harder to digest, but it helps to regulate the gastrointestinal system. It helps to a patient that's been constipated, it helps get things moving along, if you know what I'm saying, okay? But with a high fiber diet, we want to keep in mind that we want to increase their fluid intake because fiber takes a lot of extra fluid to digest. And with that being said, I'll take a little sip. Okay, we're going to talk a little bit about some eating disorders, anorexia, bulimia, and binge eating disorder. Oh, well, that was boring. That was boring. So anorexia is where the person doesn't, it's very calorie limited, okay? And most of you know these, okay? Bulimia is where a person will restrict, and then all of a sudden will eat a ton of food, and then they will purge it. And sometimes anorexia and bulimia go together because they, like a person has restricted themselves like an anorexic would, and then they kind of reach their breaking point and they just eat a ton, and then they feel guilty, and then they vomit. Okay. A person with a binge eating disorder eats kind of like a bulimic, but then never purges. Just feels extreme guilt because they ate so much, and they feel sick, but they don't vomit. All right, let's talk about a carbohydrate controlled diet. A carbohydrate controlled diet mostly follows a patient who is a diabetic, whether it's a diabetic type 1 or a diabetic type 2. These are the types of restrictions that would be, or restriction or of a restricted diet that you will see. So a diabetic type 1 will balance what they eat or what carbohydrates they eat with the amount of insulin that's injected. Okay, so usually you will see a patient's medication administration record with a meal dose of insulin. So we're going to give insulin at the time that they're going to eat, and then the dietary will know exactly how many carbohydrates to put on their tray based on how much insulin is being given. Okay, so the medication type that they get is only insulin. That's all that they have ordered. That's really all that works for them. Okay. A type 2 diabetic is a little bit more complicated in the fact that their that the patient does make some insulin and they take oral medications, okay, or they take insulin and then we kind of do a balancing act between how many carbohydrates they can have versus how much medication that they can have, okay? So type 2 diabetics may only be on anti-diabetic medications, or they could be on insulin as well. So they could be on a combination of things, which makes it a little bit trickier. For us as nurses, we need to know that we have to keep track of how much carbohydrate does my patient really eat, okay? An exchange list is, and your book talks a little bit about it, that knowing that one slice of toast is 30 grams of carbohydrate, or half of a cup of rice is 30 grams of carbohydrate, for example, okay? And if my patient doesn't want their one piece of toast, they can have rice instead. And that would be an exchange list. That would be an equal exchange for the same amount of carbohydrate, the same amount of insulin, or the same amount of medication that would be acceptable for the patient to eat, okay? Many of these patients do what we like to call as carbohydrate counting. They count, they know exactly how many carbs they can have for a meal based on their medication, and they will say, they will carb count and give insulin or medication in direct relationship to that medication. Dumping syndrome. Okay. Dumping syndrome is really not that glamorous. It's actually kind of terrible. It's a person that's had, well, it can happen to any of us. I'll be honest. It can happen to any of us if we eat something that our body is not used to and it kind of expels it really quickly. It most oftentimes happens to our patients who've had a gastric bypass or some type of surgery that alters their stomach. And the food that's ingested finds its way into the stomach and then it empties really, really quickly into the small intestine and it moves through very quickly, and your patient will have all of these syndromes. I shouldn't say all of them. Some of these symptoms, okay, sorry. They may have diarrhea, they may even vomit the food, okay? So in order to help to keep that from happening, we want to have meals small and spaced out so that the body, the altered stomach, has time to work out that food, digest it, and then move it appropriately onto the small intestine and then onto the large intestine. Lactose intolerance is another type of intolerance where a patient doesn't have a certain digestive enzyme, and that enzyme is lactase. And so that happens with milk. Some people have lactose intolerance and they don't even care. They just drink milk or have ice cream, knowing that they can survive or they will survive the symptoms. Okay. Most patients will complain of nausea, abdominal cramping, sometimes bloating, gas, and then some just have diarrhea. Okay. But it can be very uncomfortable and we can take medications, and there's now new types of milk that can minimize these symptoms as well. So modified diets. So for you'll see these as we do different diseases, and I like to do an overview before we get to the diseases because it's kind of overwhelming to do it all at once. But with patients that have like metabolic syndrome, we'll have a metabolic syndrome diet that will help with patients who are cardiac disease or have diabetes or stroke. You don't see a lot of the metabolic syndrome though. So I kind of like circle that and kind of make it like not as important. You'll see protein restricted very often for patients that have kidney failure and cirrhosis because it's really hard on the kidneys and the liver to have a lot of protein. Sodium restricted, we'll see this a lot for patients that have hypertension or, congestive heart failure, okay? Potassium modified, usually you'll see patients that have low potassium because of renal failure. It is known to help decrease hypertension with high potassium, but really truly we try to stay away from high potassium because it can alter cardiac rhythm. And so we don't want that for our cardiac patients as much. Fluid modified, you'll see this quite often, will decrease the amount of fluid that a patient takes in when they have renal failure or they have edema or they have congestive heart failure because it makes their heart have to work harder. All right, I'm going to tell you, we do everything possible to get patients to eat food through their mouth and through the gastrointestinal system. We try very hard. We will puree food, we will alter it in many different ways so that we can eat it the old-fashioned way. But if that is not possible, now why do we do that? Why do we work so hard? Why do we have a dietary department that does that? Because you're going to get the most nutrition, the most nutrients from the old-fashioned way. Even if we blend it up, we're going to get the most amount of nutrition. However, if we cannot do that, then we will insert a feeding tube. Now we've got lots of different feeding tubes, right? So we have a nasogastric tube, right? So it goes through the nose, and we're going to place these in lab. Goes into the esophagus and into the stomach, okay? That would be an NG tube, okay? A nasoduodenal tube, see this dotted line? That goes into the duodenum, okay? Into the small bowel, okay? And we can give different foods in different spots, okay? And then nasojejunal just goes a little bit further, okay? We can also place what we like to call as a PEG tube or a gastronomy tube. Don't ask me why we call it PEG tube. I have no idea, okay? PEG tube goes right into the stomach. It bypasses the nose. PEG tubes are many times placed for patients who've had a stroke, who have alteration in being able to swallow. And we don't just make that choice lightly, right? We'd make that choice if your patient has an NG tube and they're not, responding as well as we were hoping. We'll place a PEG tube and we can give them nutritional support through the PEG tube or the gastronomy tube, okay? Sometimes it's called a G tube, okay? Now, tubes placed in the stomach, okay, NG tube or a PEG tube or a gastronomy tube, are awesome, but your patient needs to be sitting up to eat, at least at a 30-degree angle, okay? And foods that are placed in the stomach have risk of aspirating, so we want to make sure that it's a patient that can tolerate sitting up for periods of time to digest appropriately, okay? Now we have tubes, right? This nasoduodenal tube, right, that goes into the nose and goes into the duodenum, okay? This is a little bit better for patients that are a little bit sicker because we still want them to be sitting up at a 30-degree angle, but the chance of them aspirating is a lot less than with a tube that's in the stomach, okay? Sometimes you'll hear nurses call this duodenal tube a small bowel feeding tube, or you'll see them refer to it as a duo tube, okay? We've got too many names, right? A tube that goes into the jejunum is a little bit deeper into the small intestine, and we'll call that a J tube. Sometimes you'll have a patient that has a tube, a PEG tube and a J tube, and they kind of like connect like this, and one's in the duodenum, this one's in the duodenum, and this one's in the stomach, and we can give different types of meds in each of those tubes. It's kind of crazy, okay? Continuous feeding is we're feeding the patient exactly as it sounds. We're giving them a continual feeding, and it looks like a shake. but it's like called like Jevity. It depends on the different, like manufacturers, but it's looks like chocolate, but it doesn't really smell like chocolate, you know what I'm saying? But it's going continuously. Okay. Bolus feeding is we would give a bolus like 2 cans of a feeding at breakfast, 2 cans at lunch, and 2 cans at dinner, right? We're giving them all of this feeding all at once. And so their body needs to be able to receive it in their stomach or in their small bowel somewhere and be okay with all of that all at once. Usually we'll start a patient on a continuous feeding, very slow, and work them up. Okay. If the feeding tubes don't work, right, whether it's NG tube or it's a PEG tube or it's a J tube or whatever it is, if that doesn't work, then we will go to intravenous nutritional support. Okay. Now, we have a couple different types. PPN, which is uh, parenteral nutrition that can go on a peripheral line. Okay, so the PN isn't for LPN, right? The PN, whoa, 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 whoa. So the PN refers to peripheral or parenteral nutrition. The P is the peripheral line. It can go into a peripheral line, which will start in lab. Okay, TPN is total parenteral nutrition, needs to go in a central line. And central lines are in the superior vena cava. Okay, lipids are fats. We give fats as well. TPN and PPN are electrolytes, like some sugar, and the lipids are just fat, and it's like white. Okay, LPNs cannot give TPN or lipids. Okay, you'll get that in block 3. So what are the effects of nutrition? Okay, if your patient doesn't eat, okay, their skin is going to break down. Okay, and there's a whole scale, okay, that kind of gives us which patients are at risk for skin breakdown. That's called a Braden scale. And if they're not eating well, that actually puts them high at risk for skin breakdown. If we don't eat, their healing is going to be delayed. If they don't eat, their coping is going to be decreased, right? I mean, I know that a lot of, just some patients just worry about, what are they able to eat or what are they not able to eat? Like chemo patients, their life revolves around how much they can eat and how they feel if they can't eat or they can eat. And that kind of is very closely tied to their overall mental health. So keep that in mind. I know it seems like a very simple thing when we have a patient's tray that's delivered, but think about how are they going to eat that? How successful, what are they going to actually eat? How can I help them with that? So we're going to do a little brief overview of fluid and electrolytes. Okay. So fluid compartments in the body, and we're going to talk more about this in lab, but we have the intracellular, which is inside the cells, okay? And we have extracellular, which is outside of the cells, okay? And we've got extracellular that's in the vascular space, and we have fluid that's in interstitial. And interstitial means it just coats and moistens all the cells in the body. So intake and output, we as nurses, we are keeping track of all the things that go in and all the things that come out. Now, we have CNAs to help us with that. There's my cat. To help us with that, okay? But some things to think about. These are all the different types of intakes and outputs. Take a look at all of the different types of intake we have, right? We've got oral intake, that's usually what's on our tray, tube feedings, IV fluids, the TPN or the PPN, if your patient's receiving blood, even ice chips, even sips of fluids we want to keep track of. We also need to keep track of different irrigations. I'm sure there are things that are on this list, or there are things that have been left off this list not intentionally, but lots of things that are intake. Now, output, right? Urine, stool, emesis, anything that we suction out of the GI system, blood that's lost, fluid that's removed during dialysis, chest tube drainage, anything that's removed from the chest tube, or anything that's removed from a dressing change or from a wound, right? Even a drain from a wound, right? So lots of different ways that we lose fluid, okay? So it's important for us to keep track of that, okay? Now water is going to move through our body through semi-permeable membranes, and it's going to move with the help of protein, or the key is albumin. Albumin is the key holder for that movement. When we don't have enough albumin, fluid gets all messed up in the body, okay? Fluid's also going to move, and electrolytes are also going to move through the body by diffusion, osmosis, and filtration. Those I would highly recommend taking a peek of in your book, so you kind of have a review of those, okay? Electrolytes, they have an electrical charge, and they move with active transport through the body. So there's a little picture here of osmosis and things moving through a semi-permeable membrane. So in our body, we've got major and minor minerals. I'm not going to talk a ton about these. I'm just going to do a quick little overview, kind of give you a little review of these minerals and the electrolytes. So sodium. Sodium is the most abundant. The kidneys excrete it. Sodium helps to truly balance our fluid. If there's high amounts of fluid, there's sure high amounts of sodium. Or I guess it's the other way around. If sodium is in high amounts, then our body will retain water. Sodium helps with nerve conduction. It's found naturally almost everywhere. We need quite a bit of it, but if we consume too much, if we consume too much, then we can develop hypertension, okay? So if we don't have enough sodium, then we have hyponatremia. Sometimes that's caused by not enough intake. Most oftentimes, a patient will come to us with low amounts of sodium because they've been vomiting or they've had long-term diarrhea. Now, on the flip side, hypernatremia, too much sodium, well, that happens very easily when people just eat too many things that have high sodium in it. We can also do this to our patients if we infuse IV fluids too rapidly in their veins. Potassium, when I think of potassium, I think of the heart. I think that it works the heart, right? It's essential in that heart function. It helps with our muscle contraction and nerve conduction. I can't speak. But it's found in fruits, vegetables, fresh meat. We all think of bananas as having high amounts of potassium, but apricots have a ton of potassium. Tomatoes have a lot of potassium. Potatoes have a lot of potassium. So lots of other things that have potassium in them. So low amounts or hypokalemia can be caused by usually the diarrhea and the vomiting. Yeah, sure, I could decrease my intake, but if I have history of diarrhea and vomiting, that's going to lower my potassium. And what would I do as the nurse? Well, increase intake, okay? Hyperkalemia, too much potassium, well, that can be caused by a couple different types of diseases like kidney disease, or if your patient's gotten a lot of old blood products. That's why, and you'll learn in block 3, we check the expiration dates of blood, because if blood gets too old, it can infuse too much potassium into a patient's body. Who knew, right? Rhabdo is rhabdomyolysis. It's a shortened for that. Rhabdomyolysis is where tissue has broken down really quickly. This happens with people that have massive amounts of bruising all over their body, or they've gotten beaten up really badly, or lots of wounds all over their body. And so that patients who are in ICU, we have to watch them for that rhabdomyolysis. So if you've got a patient that has really high levels of potassium, we can give Kayexalate. I would highlight that. We give that a ton. And that will help to pull potassium out through the stool. And then we can always do dialysis on the patient and pull potassium out that way. Chloride, very, very odd for chloride to be elevated or low on its own. Usually chloride follows sodium or it follows potassium. It's negatively charged, so it wants to be attached to one of those other two positives. Chloride is necessary for gastric juice formation. It also helps to regulate our acid-base balance. So calcium. Calcium, it's necessary for strong bones and strong teeth. It helps in blood clotting, nerve conduction, and it also helps with our muscle contraction. We'll talk more about calcium as we move forward, but truly calcium levels are important, especially when you've had a thyroidectomy. We need to make sure that we have good levels of calcium. Calcium is found in a lot of different types of foods, and if we don't have enough calcium, it can lead to bones that aren't really strong, and also can lead to hypertension, interestingly enough. So hypocalcemia can be caused if your patients had diarrhea, or they don't have enough intake, or if they've had their parathyroid removed. So the parathyroid, as many of you may or may not know, is attached to the thyroid just right behind it. So if we've removed the thyroid, we may damage the parathyroid, so that's where that thyroid surgery and parathyroids kind of come together. If we have too much calcium, that's a problem too. Because if we've got too much calcium in our bloodstream, very often, very, very rarely is it caused by increased intake. But your book talks about that, so I put that there. But people really aren't like overdosing on their milk, you know? Anyways, if you've got too much calcium in the blood supply, or in the blood system, I'm kind of talking a lot, but then we can have renal calculi, which is kidney stones, and then calcium can be pulled actually out of the bones if the parathyroid isn't working appropriately. So that's something that we keep kind of close tabs on. Phosphorus. Phosphorus has an inverse relationship to calcium. So if calcium's high, phosphorus is low, and if phosphorus is high, calcium is low, right? So they work inversely or conversely to one another. So if we don't have enough phosphorus, look, it's liver. So with a person that doesn't have enough phosphorus in the body, or hypophosphatemia, say that 10 times fast, usually it's in conjunction with impaired kidney function, okay? And it can cause muscle weakness as well. Hyperphosphatemia, too much phosphorus, can also be linked to the kidneys not working appropriately as well, okay, on the flip side. It also can be caused by increased intake. That doesn't happen so often, but it could possibly happen. Your patient may complain of numbness and tingling if they have too much phosphorus in their body. And they could have some muscle spasms as well. Okay, so think about it. If the phosphorus is high, calcium is low, and low calcium will cause these things. Good to know. Magnesium. Magnesium is interesting because magnesium has a very, very tiny window. Do you see this window of normal? It's very tiny, okay? We worry about potassium a lot, about cardiac function, but magnesium also is important in cardiac function, okay? So you see here, skeletal muscle, yep, cardiac functioning. So if we don't have enough magnesium, your patient's going to show weird things like they would with a decreased potassium, like heart, like irregular beats, irregular movements, okay? So usually your patient doesn't suffer from magnesium depletion unless they've been really, really malnourished for a while. Usually your patient doesn't have too much of an excess either unless their kidneys aren't working well or we've like given them too much, which that could happen. Sometimes we give them like extra magnesium pills or things that we didn't mean to give them, which is, gotta look out for that. Bicarb, I think this might be our last slide here. Bicarb is what kind of regulates our acid-base balance. It's the neutral to all the other acids in our body. We'll talk more about that when we do respiratory and we do ABGs and those kinds of things, but I put the baking soda here because baking soda is bicarb. But truly it helps to neutralize and acts as a buffer to keep our body from being too acidic.